The following podcast is part of a certified educational activity titled From Poor Prognosis to Emerging Clinical Potential, a Visual Journey of Targeted Therapy Innovation in Extrapulmonary Neuroendocrine Carcinomas. Access the entire activity and complete the post-test at peerview.com/PBT860. Downloadable practice aids are also available.
Hello, and welcome to this educational program from Poor Prognosis to Emerging Clinical Potential for Extrapulmonary Neuroendocrine Carcinomas. My name is Jaume Capdevila. I'm a medical oncologist at Vall d'Hebron University Hospital in Barcelona, and I will be guiding you through the visual journey on the key innovations on the DLL3 targeted therapies for patients with extrapulmonary NECs. So our goals today will be to improve our understanding on the clinical rationale and therapeutic potential of novel cell surface targets and markers expressed in extrapulmonary neuroendocrine carcinomas, augment our knowledge on recent clinical efficacy and safety data for novel targeted therapies in the management of extrapulmonary NECs, and enhance your skills to formulate team-based care strategies for the appropriate differential diagnosis, individualized treatments, and practical management of patients with extrapulmonary NECs. Let's start with the first module, rare but not forgotten, from the clinical, morphological, and pathological characteristics of these extrapulmonary neuroendocrine carcinomas. We know that neuroendocrine neoplasms in general can arise from all different parts of the body. We have more frequent sites like the lung or the GI, but we can have almost neuroendocrine neoplasms from all the parts of the body. If we look at the incidence in the general neuroendocrine neoplasm, not only carcinomas, we can see that we have a growing incidence of these tumors around the world, and in all the origins, we have some origins where the incidence is growing more quickly, like the lung, and the GI tract, and the pancreas. But in general, we have much better diagnosis today than some years ago. So this influences for sure in the better diagnosis and better characterization of the disease. And today, there are less and less neuroendocrine neoplasm patients that are misdiagnosed with other kind of cancers. We need to have some clear ideas when we talk about neuroendocrine neoplasms. We have the tumor from one side and the carcinomas from the other side. And this is morphologically guided. So I mean, when a tumor is well differentiated, so this will be called tumor itself. It's a neuroendocrine tumor, the NET, the classical NET, the classical carcinoids, for instance, are included in this classification. And the other are those that are called poorly differentiated, that are the carcinomas. And neuroendocrine carcinomas are less frequent compared to neuroendocrine tumors, but have a poorer prognosis and a more aggressive histology. It's not only a matter of differentiation, of the cell differentiation, but it's also a matter of grading. We cannot have a neuroendocrine carcinoma that it's grade 1 or grade 2. But we can have neuroendocrine tumors with grade 3. And grade 3 only is defined with the Ki67 value and the mitosis rate. So if it's over or below 20% of the Ki67, we will have G1 or G2 below 20%, or over 20%, it's G3. So we can have G3 NECs and G3 NETs. Here you can see the most recent classification. For the NETs, as I said, we can have the 3 grading system. And for neuroendocrine carcinomas, by definition, all of them will be grade 3. And we can have from small cell to large cell. The vast majority of lung neuroendocrine carcinomas, for instance, will be small cell lung cancers, but the vast majority of extrapulmonary NECs will be large cell neuroendocrine carcinomas. But it's not only a matter of differentiation and Ki67. So this is a line, an evolution of the disease. Of course, you can imagine that it's not the same to have a neuroendocrine carcinoma with a Ki67 of 30% as the same poorly differentiated neuroendocrine carcinoma with a Ki67 of 99%. So the evolution will be different, and the response and the potential response to chemotherapies or other kind of treatments will be also different. So here, the most important thing is to have a well-experienced pathologist that will first classify the tumor, if it's a NET or a neck, and then classify correctly on the Ki67 value, because this has a clear impact on the decision-making process. Because when we see the clinical representation of these patients, we can see you can see here in this table how the characteristics of NETG3 versus NECs can appear on a particular patient with a gastroenteropancreatic NET, for instance. But we have some patients that are in the middle of both situations. So a NET, well-differentiated, high Ki67, that is evolving as a neuroendocrine carcinoma. So this increases the complexity of the classical tables of classification and probability to be positive as when we do a gallium-68 scan, for instance, or an FDG PET scan. So at the time to differentiate now the diagnosis between a NEC versus a NET, it's important to add sometimes the molecular biology in the middle of the process of diagnosis. Because not always, when we are talking about the extremes of the disease, the well-differentiated or the highly poorly differentiated, it's quite easy to have the molecular and the pathology diagnosis. But if you are in the middle, so low NECs, Ki67 between 20 and 55, or NETG3s, sometimes it's not as easy as having the differentiation. So we can add here some molecular testing, such as the P53 or the retinoblastoma expressing protein that may help us to differentiate a NET versus a NETG3. When we want to do the workup and the diagnosis and the extension of the disease, here we cannot use the gallium-68 because the expression of somatostatin receptors in neuroendocrine carcinomas is usually very low. We need to rely on the sectional imaging. So MRI and CT scans are those techniques that we usually do to do the workup and to know if the patient has distant metastasis or not. And the FDG PET scan plays here a much more important role than in neuroendocrine tumors. Mainly because, as I said, the expression of somatostatin receptor, we can find some expression in low NECs, but as we higher see the Ki67, the lower probability to have expression of somatostatin receptors, and FDG will be positive in the vast majority, if it's not all, cases of neuroendocrine carcinomas. The intensity of this expression is something that it is still not well defined as a prognostic value for neuroendocrine carcinomas, but we use more FDG PET scans than gallium DOTA PET scans. When we want to use biomarkers in the blood, it's even more complex because the classical hormones that we see in neuroendocrine tumors usually are not released for neuroendocrine carcinomas. We can see paraneoplastic syndromes that are much more difficult to be diagnosed. And another thing that we may use here as a biomarker is something that in the NETs are not usually used, that these are the circulating tumor DNA. So neuroendocrine carcinomas have usually more mutations than neuroendocrine tumors, and we can detect that on the blood. So it's a completely different kind of biomarker testing, not looking for hormones for neuroendocrine carcinomas, but more on ctDNA, for instance, as an example, as other kind of more aggressive cancers. But again, this is a very early field for neuroendocrine carcinomas. So as a general view, I think that one of the main concepts here is that neuroendocrine carcinomas, even are more rare than neuroendocrine tumors, it's extremely important to differentiate and to diagnose them properly, and because the therapies are completely different and the prognosis is different. And there's a new group that it's the new one included in the last classification of the WHO classification, that this is the NETG3, that increases a little bit the complexity, but reflects the reality. So they are well-differentiated NETG3 tumors that usually evolve as a NETG2 tumor, and those that are neuroendocrine carcinomas that are usually highly aggressive, but with some peculiarities. It's not as uniform as the classical small cell lung cancer, that this is the most frequent and most well-known neuroendocrine carcinoma. So extrapulmonary NECs are not as homogeneous as the lung counterpart, and we need to do a proper and accurate diagnosis to guide the thorax. Talking about these therapies, how we may see innovations for these extrapulmonary NECs, you will see that the situation has not been easy during many, many years. And now we are starting to see the light and the option for these patients with extrapulmonary NECs. I want to start only with a classical case. So this is a woman, 79-year-old, that was diagnosed with a neuroendocrine carcinoma of the biliary tract on the liver with multiple lesions, so with an advanced stage. So if we see this patient starting to be quite old, 79 years old, with a neuroendocrine carcinoma, advanced disease. So if we look at the literature and we see which is the best treatment option for this patient, so probably you all are aware that chemotherapy and combinations with platinum is the most adequate therapy for this particular patient. But this is not as easy as giving platinum etoposide to everyone. So guidelines for neuroendocrine carcinoma are also quickly evolving. It's not only a matter of having the diagnosis. As I said before, we need to have an appropriate cross-sectional imaging, an FDG PET imaging. The pathology review is extremely important. Here we can add the concept of molecular profiling and why not performing next generation sequencing, and you will see that later on. And unfortunately, the vast majority of these patients will have the initial diagnosis with distant metastasis, so resectable options are quite anecdotal. And the debut of the disease is important because sometimes patients have a quite poor performance status that increases even more the complexity of treating these patients. But if everything is in place and we can start a systemic therapy, so the first treatment option today is platinum etoposide or platinum irinotecan. We have evidence for both treatment combinations, but it's a strong chemotherapy. And added that to some certain ages, like the case that I just introduced to you, or the performance status that sometimes it's not easy to deal with, first-line chemotherapy could be a challenge. We may start chemotherapy as first line, and what happens after progression to first line? So the scenario for second line is quite poor. We have few treatment options, and you see that better in a minute, because it's important to know, as I said during all my presentation, that the heterogeneity is important. It's not the same to have an esophageal small cell neuroendocrine carcinoma that can be treated even when it's locally with chemoradiotherapy, compared to a large cell neuroendocrine carcinoma of the rectum, locally advanced with all the problems that this situation may produce with distant metastasis upfront. So heterogeneity is important, and all the workup should be done in the proper way and in the view that we can orientate the systemic therapy. Because systemic therapy, as I showed you before, can be clearly defined in first treatment line. So platinum etoposide can show between 30 and 50% of overall response rate. This is much less than we can see in small cell lung cancer, for instance. So again, it's a completely different disease compared to small cell lung cancer. Progression-free survival usually is below 6 months, and the overall survival is usually less than 1 year. And this is the reality for extrapulmonary NECs coming from GI, that these are the majority of tumors, and GU is the second most frequent origin, including some part of them coming from unknown primaries. If we go for second line, irinotecan-based chemotherapies or oxaliplatin-based chemotherapies, simulating the chemotherapies that we are using for GI cancers, or even topotecan or temozolomide, because we use temozolomide in well-differentiated NETs, the probability of response is usually below 10%. Have some reports something with responses slightly over, but usually the responses are below 10%. The median progression-free survival just arrived to the first scan. So the first 2-3 months, half of the patients will progress, and the survival is usually around 6 months. So doing research in neuroendocrine carcinomas is extremely difficult. And here you can see only a couple of examples of our national working group, the GEP-NET group that did academic trials trying to combine immune checkpoint inhibitors with an anti-PD-L1 and CTLA-4, or combinations with multi-kinase inhibitors plus anti-PD-L1s. And what we saw is anecdotic responses, usually below 10%, so as chemotherapy, and no really long survivors. If it's not a biomarker-driven immunotherapy like MSI high, all the others, the responses and the long-term benefit is quite disappointing. We have been testing that with chemotherapies, and this is another example of our academic work in the GEP-NET group, combining platinum etoposide plus nivolumab. We showed 50% partial responses, maybe slightly higher than we may expect with chemotherapy alone, but this is a single-arm clinical trial, so no practice changing. There's a clinical trial in the US recruiting that is testing the addition of atezolizumab with chemotherapy as in combination or in maintenance, as trying to simulate the standard of care of small cell lung cancer. The study is still recruiting. We will see what happens here. This could be the first phase 3 study with immunotherapy that may finish recruitment the first time of history, but we will see which is the impact of only adding one immune checkpoint inhibitor with chemotherapy. Again, thinking that extrapulmonary NECs are not small cell lung cancer. Why is the field so interesting today? Because we can see potential targets that are shared with the small cell lung cancer, and this is not another one that DLL3. So this receptor of the Notch pathway, it's overexpressed in the vast majority of small cell lung cancers and around 80% of extrapulmonary NECs. So we have a potential target, and now we have a clear development on potential on new targeted therapies for these DLL3 expressing tumors. And we are happy that we have this target in extrapulmonary NECs, positioning this disease in the field of oncology in general. We have different approaches. Those that are more advanced are the immunotherapy that try to engage the immune system, the T-cell engagers. And we have several examples like obrixtamig with data or tarlatamab. And we have also other three specific antibodies that try to increase the half-life with initial data reported last year. And we have a global development against this potential target in extrapulmonary NECs, including ADCs and radioligand therapies. One of the most advanced, or maybe the most advanced compound for extrapulmonary NECs in the field of immunotherapy is obrixtamig. Obrixtamig is an IgG-like DLL3 T-cell engager that targets the CD3 expressed in the T cell and the DLL3 expressed in the cancer cell, and this produces this cytolytic synapse that can produce the cancer cell apoptosis, and also releasing several cytokines that can recruit more immune cells and produce more tumor death. So what we have been reporting during the last year, or half a year, is the results of the phase 1 dose escalation study. And this is a classical dose escalation study of obrixtamig in DLL3 positive tumors. We have two cohorts with those that we consider potentially active. And this is what we have been reported during this year. So we have a couple of messages here. The first one is that for this dose escalation phase 1 study, we clearly showed that only those tumors with high DLL3 expression, and high DLL3 expression means more than 50% of the tumor cells positive for DLL3 immune staining, are those that have more chances to have responses to these T-cell engagers. And those that are DLL3 low, below 50% of expression, the probability to have a response is much lower. So I will show you immediately the results of the phase 1 study, but this is extremely important because we are generating the first biomarker for patient selection in extrapulmonary NECs. And again, this is not a small cell lung cancer. We have some rules for small cell lung cancer, and we need to create and generate new ones for extrapulmonary NECs. The probability to have a DLL3 high tumor is 50%. So if we can, that 80% of the extrapulmonary NECs are DLL3 positive, so the whole population of DLL3, of the whole population of extrapulmonary NECs, 40% of them will be DLL3 high. So it's a biomarker that it's expressed in a good percentage of tumors. So what we have been reporting is the results of 2 different cohorts, DL3 high and DL3 low, included in this phase 1 study for extrapulmonary neuroendocrine carcinomas. And what we can see first is that the safety is exactly the same. I will go on the safety in few minutes, but cytokine release syndromes are one of the typical side effects of these T-cell engagers that are seen in the vast majority of patients that we treat. But we have also some other side effects like GI, fatigue, and the ICANS, these potential neurological side effects that we should be aware about them. Regarding efficacy, we have not seen real good responses in DLL3 low, and we have seen responses between 40 and 50% in the GI and GU origins for DLL3 high, included in this obrixtamig phase 1 study. And not only the probability of having a response, this is a heavily pretreated population, usually with more than 2 prior systemic treatment lines received. And we have a high disease control rate that arrived between 60 and 70%. So patients that have almost no treatment options in second, third line, we are seeing responses and disease control rate, and regardless the origin, so GU and GI, that these are the main origins that were included in the phase 1 study, we have the same probability to have responses, and the disease control rate and the duration of those responses. So these are responses of good quality, and many of them of long duration. So the duration of these responses are around 8 months in the DLL3 high, with no median progression-free survival yet arrived. This is the data coming from the obrixtamig phase 1 study, and we have more data coming. A couple of years ago at ASCO meeting, a tri-specific monoclonal antibody targeting DLL3, CD3, and also albumin to try to increase the half-life of the product also reported nice results. So this is only to highlight that the research in pulmonary and extrapulmonary neuroendocrine tumors focused on the DLL3 expression is now, let's say, fashion, because we can have finally found a potential biomarker for drug development. And the field is evolving quickly, and we have the phase 1 study combining chemotherapy and obrixtamig in first-line extrapulmonary NECs that is running quickly, and we are starting to report the first initial data that will be complemented during the 2026 academic course. And this is the phase 1 study that for sure will lead to the design of a phase 3 global study comparing chemotherapy versus chemotherapy plus obrixtamig. We came to if we return to the patient, the patient with 79 years old started systemic therapy first line, platinum etoposide, with no good response. As I said before, extrapulmonary NECs are not responding as small cell lung cancer, and therapy should be discontinued after 6 months due to poor tolerability and for the lack of response. So here we have a problem, or we had a problem, or we still have a problem. So which is the best treatment option for this patient in second line? More chemotherapy in almost a patient with almost 80 years old, with a low probability of response, with high probability of toxicity. So this patient was included in the phase 1 study. She received Orixtamib, and she had a very rapid improvement of her symptoms. A partial response was observed just after 6 weeks on therapy, and more than 2.5 years after starting therapy, she maintains the partial response. So this is what we may understand as a personalized therapy for extrapulmonary NECs, something that was not easy to find until recently, very recently. And I only want to highlight that this patient had almost no side effects, and this is what we will see in the vast majority of our patients: some fever at the beginning that appears in the first infusions and nothing else after that. But imagine that we have here a more complex cytokine release syndrome. We have some neurological symptoms that we may sometimes misinterpret as an ICANS or a normal situation of the patient in this advanced stage. The complexity of the management can be much higher. So, efficacy is there. The evidence that we have is what we have. No, the potential arrival of these T-cell engagers is almost here, but we need to deal with a new potential safety profile for our patients with extrapulmonary NECs, and we need to learn about that. And what we need to learn, so what we need to mainly learn is how to manage the cytokine release syndrome. In a phase 1 study, all patients need to be hospitalized and it's extremely well monitored. But in the future, when these drugs will arrive to the market, we need to be more realistic on treating these patients in the routine practice. So we need to deal with cytokine release syndromes. And cytokine release syndromes are almost there in the vast majority of patients. It's true that in the vast majority, this is grade 1, and a few cases are grade 2, and anecdotic cases are grade 3, where the situation starts to be slightly more complex. We have other side effects like GI toxicity, and the other side effect that I want to highlight is the ICANS. The ICANS are easily underdiagnosed, and the complexity of this immune effector cell-associated neurotoxicity that can produce many different types of neurological symptoms are difficult sometimes to diagnose. As you can imagine, if a patient of 80 years old that is diagnosed with an advanced disease that is slightly disorientated, which is the cause of that. This is the disease, this is the chemotherapy that she received before, all the situation, or this is an initial ICAN. So we need to learn how to manage that and how we may not even worsen the potential neurological toxicity, because the cytokine release syndrome is something that is there, and we learn from the hematological CAR T-cell therapies. We know there are good guidelines how we may increasingly increase the complexity of the therapy of the cytokine release syndrome, but we also may pay attention that the vast majority of our patients will have grade 1 cytokine release syndrome grade 1. So this means fever, and this could be managed with completely symptomatic treatment. Grade 2, that this increases the fever. We can see hypotension, some problems with hypoxia, and this will be monitored in the hospital. But we have a range between grade 1 and grade 2 that can be rapidly treated, usually with corticoids, to try to avoid moving from grade 1 to grade 2. And this is something that we are learning quite quickly, and we are treating aggressively our patients to try to keep them on grade 1 and to avoid to arrive to grade 2, because if it arrives to grade 2 and it's a clear cytokine release syndrome and there are no ICANS, the interleukin-6 receptor antibodies are rapidly being used in many centers. But if the patient has an ICAN, this can worsen the ICAN. So the complexity and the multidisciplinary management of these patients is mandatory. And this is something that we know from the very beginning, that all patients with neuroendocrine neoplasms should be managed from a multidisciplinary tumor board. But now that we are increasing the complexity of neuroendocrine carcinomas, not only because of the evolution, because they have a worse prognosis, they have more symptoms, and now with the new therapies, we may have new side effects that maybe the NET field are not particularly used, we need to increase the message that the MDT management is mandatory. Because it's not only a matter, and we have been discussing, the focus of this session is the DLL3 as a target therapy, but we have more potential targets in neuroendocrine carcinomas. And if we do not do the NGS, for instance, and trying to find a BRAF mutation in a color origin or an ALK or an NTRK fusion in any kind of origin of a neuroendocrine carcinoma, even this is less than 1% of the probability to find this kind of alteration, we are missing the opportunity to treat our patients with a personalized therapy. With that, I would like to give some final messages. So the first one is that it's extremely important to differentiate NET-G3 versus NEC, and between the NECs, the small cell lung cancer and the extrapulmonary NECs, that, as I said, the vast majority will not be small cell, will be large cell, except the esophageal origin. So it's extremely important, and it's important also to do not translate the data that we have in the small cell lung cancer in extrapulmonary NECs, because if not, we will fail when we treat our patients. Personalized medicine is possible in patients with extrapulmonary NECs, even more if we copy-paste some of the targets that we see in a small cell, and we need to learn how these are expressed and how the patients are going on in extrapulmonary NECs. DLL3 is a good target, and I think that I will not make a mistake if I'm saying that the DLL3 potential target will not only rely on neuroendocrine carcinomas. We will see an expanding of different kind of tumors targeting DLL3 as it's a good potential biomarker. Obrixtamig today is the most advanced T-cell engager with good data in extrapulmonary NECs, and I have no doubts that we will continue seeing a good drug development targeting DLL3 in extrapulmonary NECs. With that, I would like to thank you for attending this educational session on targeted therapies for extrapulmonary NECs. I hope you found this program informative and useful for your practice. And again, thank you so much for watching.
Thank you for listening. Remember to download the practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/PBT860.